Awesome. Hey, everybody. I'm Matt Wellington. I'm the Associate Director of Maine Public Health Association, and I'll be moderating today's webinar. And welcome to the second installment of our webinar series, Cannabis in Maine, Public Health Policy and Impacts. And today's webinar will focus on youth prevention strategies. If you missed the first webinar, don't worry. You can check out the recording of that on Maine Public Health Association's YouTube page. And the first webinar covered general health impacts of cannabis use, what we know and what we don't know. So feel free to check that out if you missed it. And we've got a couple of great speakers who are going to share evidence-based prevention strategies with us. And I'll introduce them in just a moment. But first, I want to go through some housekeeping items here. Oh, there we go. So this project is supported by the Health Resources and Services Administration of the U.S. Department of Health and Human Services as part of an award to the public health training centers. The contents of the webinar don't necessarily represent the views of or an endorsement by HRSA, HHS, or the U.S. government. And you can receive continuing education credits for today's webinar if you go to the link on the slides here, which I'll also put in the chat. You can go through the process and just choose Cannabis in Maine from the drop-down menu. And a big thanks to our partners. We've got co-sponsors for this webinar series. Of course, Maine Public Health Association and our Alcohol, Tobacco, and Other Drugs member section is a host, as well as the Maine Medical Association, Maine chapter of the American Academy of Pediatrics, and the New England Public Health Training Center. So thank you to our sponsors for helping us put this together. Okay, a couple guidelines for today's webinar. Everybody's muted. This is a webinar, so folks are on mute. You can't go off video. We will take questions once we get to that point in the agenda. Our speakers are going to kick off things with remarks of their own, but we will have good time for questions. And when that happens, I'll let folks know, and you should use the Q&A function to submit your live questions, and I will do my best to get those to the speakers. And then last thing is that we have an evaluation that we use for HRSA. So stay online for just a few minutes after the webinar and fill out that survey. It's super quick. It'll pop right up on your screen when I hit the poll. So please make sure to do that. It helps with our reporting to HRSA. And with that, our speakers. So I'm very grateful to have Leanne Dodge from SoPo Unite and Rob Rogers from Kennebec Behavioral Health with us here today. And I'll let them introduce themselves a bit more once they get into their presentations. So I will leave it at that. And I think, Rob, you are going to kick us off. Is that right? So I'll pass things to you and stop sharing my screen. Okay.
Great. Thank you. So hello, everyone. My name is Rob Rogers. I'm the Director of Substance Use Prevention and Grant Services at Kennebec Behavioral Health, primarily working in Somerset and Kennebec County. But I do work for a behavioral health agency that extends beyond those county lines. So I'm currently not working specifically in cannabis prevention, but I have previous experience in doing that and spent a lot of time examining what are some of the evidence-based practices that we can utilize in trying to reduce cannabis use, particularly among our youth. And one of the things I think that's really important to understand is, first and foremost, what are we talking about when we say prevention? For the sake of this presentation, we're really talking about primary prevention. And this is prior to a diagnosable cannabis use disorder. It looks at strategies intended to prevent or reduce the risk of its development. We currently operate from the spectrum of mental, emotional, and behavioral interventions. This is formally referred to as the continuum of care model presented by the Institute of Medicine in 1994. And when we look at that continuum, as I mentioned earlier, prevention is what happens before the person is diagnosed, in this case with a cannabis use disorder. And when we look at sort of those categories or populations, we have universal prevention, and this is really prevention geared towards the general public, sort of everyone within a community. If we're doing stuff within a school, we might think about programming that occurs with all 7th graders versus a select group of 7th graders. We then have selective, and this is really geared towards individuals or population subgroups whose risk of developing a substance use disorder is significantly higher than average. It focuses on biological, psychological, or social risk factors and is designed for those whose life situations expose them to higher levels of risk factors than the general population. And then the third group is our indicated population. And this is individuals who are identified as having minimal but detectable signs or symptoms that are foreshadowing a disorder. Interventions focus on the immediate risk and protective factors present in the environment surrounding individuals. Sometimes we hear prevention being used and it's describing harm reduction. So I'm going to speak very briefly about harm reduction from the lens of cannabis use. Harm reduction is viewed as prevention, but it's not primary prevention. Harm reduction is a proactive and evidence-based approach to reduce the negative personal and public health impacts of behavior associated with substance use at both the individual and community levels. It encompasses collaboration, respect, acceptance, compassion, and empowerment. When we think about harm reduction in cannabis use, this might involve having a discussion with somebody who isn't ready to stop their use of cannabis. Okay. But how do we reduce the risks? So we might talk about, knowing your source. Where are you getting your cannabis from? Not using alone. And even having discussions if we don't know our source. We recognize through conversations with law enforcement and other preventionists, we know that a portion of the cannabis supply is also containing other drugs such as fentanyl, which is resulting in overdose deaths. So we talk about the use of naloxone, even if you're using cannabis. So some of those things are harm reduction approaches when we think about cannabis use. When we look at some of our strategies, part of this is about raising awareness and providing information so people can make informed decisions. I'm not going to go in great detail on this. I encourage you to tune into the other sessions because they're going to go into more detail. But one of the things I've seen a lot, and it was really one of the most requested presentations, more so from service providers, teachers, and people in the community, was really understanding that difference between cannabis, THC, CBD, hemp, and then it gets confusing with retail or the adult use market and then medical. So other people are going to be talking about that. I just wanted to bring that to the forefront, like really having those discussions and raising people's awareness to those differences is one aspect of prevention. When we look at some primary prevention approaches or interventions, I'm going to list several things that are options. I'm really giving you a very high level overview of these interventions. We don't have time today to go into great detail on them, but these are things that you as a provider, a parent, somebody in the public could be thinking about as strategies that you could implement. I would also encourage you, if this is something you're concerned about or want to have further discussion with, is really look and see who are those prevention providers in your community. We have the Maine Prevention Network. We have drug-free community coalitions. There are people doing this work and addressing cannabis specifically in every county in the state. So some of the things we talk about, and they're nice because they can cross different substances, right? So the first one I'm going to talk about is safe storage. So there's an initiative in Maine working with the retail industry and the medical market around having conversations with people purchasing cannabis on safe storage of their drug. This also applies when we talk about prescription drugs and opiates and, illicit drugs, alcohol. Where are we storing it? Okay. if our youth don't have easy access to it, we're reducing that risk that they will engage in the use of that substance. Another one is to think about pricing and promotion. So what work can you do in your community or municipality around pricing and promotion of cannabis products? If you have a business, how many signs are they allowed to have outside? Are there any limitations on that? How many businesses does your town allow to have and have operating within a certain radius? Another thing to think about is social access or social hosting and the difference between retail access. So they're really two different things. When we talk about social access, this is if I'm engaging in the use of cannabis, where am I getting it from? Am I getting it from my friends? Is my older brother giving it to me? Are my parents giving it to me? So where am I accessing it? And is it easy to access? Having conversations with people about reducing access. And this is also an opportunity to have conversations with parents around what are your expectations related to the use of substances for your child. Oftentimes what I've heard is there's this assumption. Parents say, my kids know what I expect out of them. We need to be very clear and specify this to our children. So having those expectations put out there. Retail access is more about, does a minor have the ability to walk into a medical establishment or a retail establishment and make a purchase while underage? Okay, so some of this comes down to working with businesses around reading IDs, how to refuse sales, those sorts of things. Very similar to what we've done in the alcohol industry around beverage seller or server training. So now it's looking at another industry and looking at the cannabis industry around some of those similar processes. Can also think about drug impairment detection training. I've done some of this with employers and with schools. This has to go beyond just the, I can smell it, right? Back in the day, people, they would, smell it, and you might have a student that got in trouble because they smelled like cannabis. We know that we have children that may be in environments where they're exposed to cannabis. They may have parents that are growing because they can legally do that in the state. We might have kids that are riding in cars to school and they have a parent that's smoking while they're driving. So just because I can smell cannabis doesn't mean that person is using cannabis. There might be an appropriate intervention, but it might not be a treatment-oriented intervention. We can also think about enforcement of laws. So what are we doing with law enforcement, or if we're in the school, if there's a school resource officer or with administration around compliance checks and party patrols? We might do parking lot surveillance at some of the cannabis businesses. Very similar to alcohol, where we did shoulder tap operations. Something like that could be done with cannabis industries as well. Do you have youth that are outside trying to get somebody that's of age to make a purchase for them? That's really the premise behind shoulder tap operations. And then having high visibility of enforcement from law enforcement and really looking at, do these establishments recognize that people may be coming in and doing some of those compliance checks and making sure that laws are being followed? And then policy efforts, working with municipalities, schools, colleges, work sites. This could also be hospitals around existing policies. When cannabis first became legal, we had a lot of messaging out there around tobacco-free policies or tobacco-free campuses. Some had signage that was tobacco-free and some had smoke-free. So still working with those businesses around, what do your current policies have? Do they need to be taken off the shelf and dusted off and, reread. We have to revisit those policies. And if we don't have language in there about being smoke-free, that's one fairly easy change that could be implemented, because in Maine, unless this is changed, and I'm not aware of it, so Leanne or Matt, I would ask you to chime in. The aerosol that is produced from an electronic vaping product in the state of Maine is classified as smoked. So any type of smoked form, either in what I would say traditional cannabis, like a joint, or if it's being vaped, both of that is considered smoke in the state of Maine. We can then, and everything I just listed falls under sort of this grouping of an environmental strategy. And environmental strategies establishes or changes community conditions in order to influence the incidence of use. We can also look at problem identification and referral to treatment. Some of this happens through SBIRT. Many of you may have heard of this: screening, brief intervention, referral to treatment. So if I've screened somebody and they are engaging in the use of cannabis, having a brief intervention and a conversation about them, with them about their use is one step. We can look at some very specific evidence-based screening tools that will assess or screen for any substance. And then there is one specifically designed for cannabis, which is called the CUDIT, C-U-D-I-T. It's the Cannabis Use Disorder Identification Test. Some other tools that are out there are the audit, the DAST, and then there's the CRAFT, which is geared specifically towards adolescents. And then knowing your resources. So if I'm conducting screening and I'm doing brief intervention, and I do have somebody, maybe we're at that point where I'm crossing that line from primary prevention to referral to treatment, I'm in a different phase within the spectrum now. Okay. And I need to know, where are those resources? And when we're talking about adolescents, those resources are getting harder to find. Many of the programs I speak to doing adolescent treatment, they've either stopped serving adolescents or they have very long waiting lists. We also have some brief intervention tools or programs that we can utilize. One that I'm very familiar with, as well as Leanne, is SERP, the Student Intervention Reintegration Program. This utilizes the curriculum called Prime for Life. And it is a 12-hour program where students are able to reflect on their own use and ultimately, look at, am I protecting the things that value most in my life? It's the same program they use in the state for driving related offenses. And I think with that, I'm looking at the time. I am going to say one last thing, thinking about community-based process. We mentioned reaching out and seeking out those coalitions in your communities. They are always looking for coalition members, and they want to have representation from multiple sectors. So if you're interested, please reach out to them. And with that, I'm going to turn it over to you, Leanne.
Thank you, Rob.
Great.
And just a note too, before we pass to Leanne, so Rob wasn't using a PowerPoint slide, but if you do want some of the resources that he's referenced, Rob, would you be willing to share some information in the chat with people? Awesome.
Absolutely.
Great. So Leanne is using slides and I will be the slide sharer. So I'm going to share my screen, and Leanne, when you want me to go to the next slide, just give me a flag of some kind and I'll switch it over. So give me 1 sec. And then after Leanne's remarks, we'll get into the Q&A. So I saw some questions already come into the Q&A. We'll hold on to those. And then when the time comes, I'll direct those to the speakers.
Great. Thanks so much for being my clicker. That stuff stresses me out. Hi, everybody. I'm Leanne Dodge, and I am, like Rob, a certified prevention specialist. Rob is way more than that, but I am that part. And I will go over a few slides, and we really do encourage you to reach out to both of us. We'll share our email addresses so you can have the slideshow or our information for sure. And one of the things that I will talk a little bit about, I've also been a DEEP instructor for 20 years, and that is the class driver education evaluation programs for OUI offenders here in Maine. And I've always taught the under 21 program. And I will share some examples of cannabis impairment with drivers, a few little anecdotes from teaching that. But what I'm going to talk to you all about is a bit about the brain and the young brain. And if you haven't heard the previous webinar, please listen to it, especially, well, all of it's fabulous, but also the psychiatrist that spoke about the young brain and mental health. It's really great information that he has for that too. So a little bit about this. Sometimes people probably, if anyone out here, I know there's a lot of you out here in prevention, that you might hear from folks, what are you doing to fight the opioid crisis? And I often say, hey, you know what? Most people don't start with opioids. They start with alcohol, cannabis, nicotine. And that's what I'm the program director of one of the drug-free community coalitions down here in South Portland. My office is in the high school, so I'm very lucky to be on site with young folks. And it's a half day, so hopefully the bells aren't going to ring during my 20 minutes, but we'll see. So I want to talk to you a little bit about that, that the brain is best for learning without much effort from 13 to 20. And so you'll meet students who we have a lot of multilingual learners, students now, and they can speak 5 languages, or students that play 4 sports or 5 instruments, right? Like the brain's so great for learning from that age. And you can still learn after 20, so that's good news, but really best for learning. So unfortunately, 90% of addiction starts before 18. So we have this window of opportunity to do prevention and intervention, and it flies by. Started my 8th year here, and students it's a minute that they're here. So we have to do this work now before we get to, as Lexi Perry said in the first one, the highest risk users are 18 to 25-year-olds. So we need to do this work now. The other thing we know about the brain is that part of the brain that's ready to take risks is fully developed at age 13. And so I often ask students, like, have your parents ever said, what were you thinking? Or would you jump off a bridge if your friend, and some of the kids go, I am the friend that gets the other kids to jump off the bridge. So we actually do want students to take risks at a young age, healthy risks, which always sounds kind of dorky, like healthy alternatives, but we really want them to take risks, which means join a club, try out for the play, try a new instrument, all those things that the brain is ready to do. So do that now. And again, as we know, the brain's not fully developed till someone's in their mid-20s. And let's remember, it's not just you wake up on your 25th birthday and like, hey, man, I've got great judgment and reasoning and caution. It happens in your developing in your environment and your experiences. So it's not just like at 25, everyone's got great judgment. So thinking about what we can do while they're young to help with that brain development. So we know that cannabis is affecting a few key things. And one of the things I do is I have people in a class setting, health classes, both in middle school and high school level, on the whiteboard, I write down, what are you good at? Who plays a sport? Which ones? Who plays an instrument? Any artists here? Anybody in theater? And we write it all over the board, all the great things that they're into, that they're kind of good at, and who can speak more than one language, etc. And then we talk about, well, how does cannabis, and again, other substances we talk about too, but how does cannabis affect those things you're good at or that you love doing? So we talk about short-term memory, that people, and I'll say, can you have long-term memory before having short-term memory? And they're like, yeah, no, wait. Okay, so right. So in class, if you're not gathering any information, it doesn't get stored. Does the teacher go over everything again every class in case someone was impaired? No, right? It keeps going. Working memory is similar, that adding new information to what your brain already knows. So that gets impaired with cannabis, that you can't add on new information to stuff you might know. Also, what's really critical is that people do not go into REM sleep, rapid eye movement, with alcohol or cannabis. And well, what's REM sleep? And people go rapid eye movement or when you dream. It's actually one of the deepest phases in sleep. You go into it every 90 minutes throughout the night. And in that REM sleep, you do your overall immune system kind of gets restored. Anything you learned in the day gets stored into long-term memory while you're in REM sleep. And the key thing is you also do problem solving while you're in REM sleep. Isn't that fabulous? Have you ever gone to bed and had someone say, you know, you're fretting about something for the next day and someone says, just sleep on it. You'll feel better tomorrow. And sometimes people don't sleep on it well and they don't feel better. Or other people do like, yeah, okay, cool. Yeah, I'm going to try out for the play because they probably went into REM sleep. The tricky thing is cannabis and alcohol, you don't go into REM sleep. So even if you got 10 hours of sleep, you did not get REM sleep. So all those things that it's good at is not happening. And oftentimes you'll hear people go, I use it to help me fall asleep, to sleep. Or you'll see signs saying that. It helps with anxiety. It helps with sleep. No, it helps you fall asleep, but you don't get good quality sleep. And have you ever not gotten good sleep? Doesn't that cause you to be anxious if you're not getting good sleep? So you're thinking like, okay, you're taking the thing that you're trying to fix and it's causing it. The other thing that's really a weird thing that we learn as in the Prime for Life curriculum is about state-dependent restriction, which means if you learn something when you're impaired, or let me flip that. When you learn something when you're sober, it's best recalled when you're sober. But if you learn something when you're impaired, really on any substance, you're better at it when you're impaired again. And that always sticks with students like, what? That's what? And you go, yeah, usually like with alcohol, it's often social skills that you might learn. What do you do at a party? Dancing, talking to people, drinking games. That people, if they start using those skills, they're actually better at it when they're using. Same with cannabis. Some people will again say, I can't sleep without it, or I actually drive better. And that's a little worrisome that someone, when did you learn to drive? When I was using cannabis, right? Like that's not good, those skills. And so over time, someone can't access those skills without using. And so they will use more often. And now it's not just funsy social skills, but it can be any skill that someone has, like I can't go to work without using, I don't function as well. So that's something critical. And then we are seeing way more mental health troubles from cannabis. So depression increases, anxiety, more suicidal ideation, also schizophrenia. Now, again, the psychiatrist that came before us, it doesn't cause schizophrenia, but it can bring it out in a brain where it was not going to come out, especially if there's genetic risk. And that's, to have psychosis like that is lifelong can be really traumatic. So really looking at mental health outcomes. And this again can happen for an adult, but definitely more likely to happen in the young brain. The other quick things I was going to tell you, a few driving pieces. So here's some of the stories students would tell me in the deep class. One would say, boy, I couldn't figure out which foot to put on which pedal when I was high. Or I had really slow reaction time. So I'm going 30 on the highway. And you might see this when you're driving. You're like, hello, can you get out of the left lane, please? Another student talked about he went through a sobriety checkpoint in Westbrook, which was great. He made it through it, even though he was using cannabis. But then because of his poor short-term memory, he forgot where he was and went back through and got no UI. So not to make fun of that, but you're like, okay, it has an impact. And if just a few things also for athletes, what we know about cannabis and how it can affect athletics is concentration and coordination is off, increased heart rate and blood pressure, which people are always excited, like, really? It increases your blood pressure? I would think as a sedative, it would slow it down, but no, it increases blood pressure, increases your heart rate, reaction time, steadiness, all those things can impact if someone's an athlete, and not just like I used right before the game, but this can have long-lasting impacts. So let's move on to the next slide, if we will. Thank you, Matt. Okay, so I'm going to go over quickly what works in prevention, what doesn't, and I'm going to talk about our restorative policy and athletic code we have here in South Portland, and also share some resources. So I know I hope I'm talking fast enough to make sure we get all this in. But let's start about what works. And one of the key things, and on that first slide, you might have seen a picture, that's our youth committee for SoPo Unite. And that started in 2016 with 3 students. And now we've had close to 400 that have been part of the group who have now, the starters, have graduated from college. And it's not the goody-goody tattletale group, the NARC committee. It's really a variety of students from athletes to musicians to all kinds of students. And we've had 70 siblings. So it's kind of like a peer pressured students in the hallway kind of look at me like, I know I'm supposed to be in it because my older brother was in it, but I don't have time to, like, it's okay. You don't have to be in it, but you should be. But anyway, so that group has grown. So one of the key things I do want to talk about is having peers involved. And we'll talk about that in a minute. But one of the things in the next slide after this, I'll go over what our restorative policy is in our athletic code. But so that's been very important when you think about out of school suspension, which we no longer do. What do you think someone was doing for 7 to 10 days that they were home? Probably not homework, right? And lots of stigma and shame. And we know that suspending students doesn't change behavior, which is really our ultimate goal. We forget that. We're like, just get them out of here. And when they would come back, like there was no re-entry, like, what did you learn from this? It's just like, get on back to class. So we'll talk about that and I'll show you the flow chart in a minute. But I do want to mention peer influence on each other. And there's a great program through the tobacco folks called Sidekicks, which teaches peers how to talk to their peers about risky behaviors. And when you think about it, who do peers go to typically first? Each other. And not like, I think I'll speak with the assistant principal about my choices, right? Like probably going to go to a peer first. So really helping students with that. And so that's a great program to have. And you can teach it at middle school level and high school level. And one of the cool things about high school students is when we started our group, they said, we don't really want to do any education or anything like that for our peers, but we will go to the middle schools. And so that's been a big thing, how we really drew a lot of people like, yeah, we'll go down and visit and play Jeopardy and answer anonymous questions about high school. And we went last spring. And after we left, a teacher said to me, this is what the students said. This is what the middle schoolers said. They said, I am never using drugs. And also they said, and now I'm not afraid to go to the high school. So in 40 minutes, those two things, and that's in the moment. But one of the things we know about substance use, oftentimes it increases when there's a transition in someone's life. From 8th grade to 9th grade, we used to see a spike in use like the summer before they got to high school. Well, why is that? Well, risk-taking, and I'm kind of nervous about going to the high school. Also increase after high school to beyond that. There's sometimes an increase. So really thinking about how can peers and older peers have an influence on younger peers. And a couple other quick, pieces about that is having alumni come back to high school students. And one of the cool things, some of our alumni, we had a little gathering last year, and a really great piece was they said, you know what, in college, no one is popular. And that just stuck like, wait a minute, all through high school, you're fretting about fitting in and being liked and stuff. And when you get out of high school, no one cares. And so just sharing some of that good information, or I did some work in Gorham with athletes and had high school kids talking to 8th grade athletes. And they just said a moment of, you know what, using looks cool in the beginning, but then it really doesn't look cool later on. And again, to hear that from an older peer has more of an impact than someone older. So again, peer-to-peer, also social norms. If people think everyone's doing it, they're more likely to do it. Turns out most youth are not using cannabis. So really like less than 20% of the high school students in the state are using. So really getting people to think that. And sometimes they go, I don't believe that. I think everyone is using right now. No, not true. And sharing the data. Again, as Rob's gone over some of this, reducing access and all of that, you know, having places give out lock boxes and all of that to reduce access to using. And just a piece again about youth, we have a flavor tobacco ban in South Portland. And we thought, well, cool, that at least that no one will start using, no new starters. However, you know, but probably the kids have already started that ship sail. They're gonna go over and get it in wherever, Scarborough. Turns out some of our students have come to our social workers and said, I'm quitting. I can't get flavors and my supplier is charging more. So again, thinking about reducing access, it really does work, not just for primary, I haven't ever started, but also for folks who may have started. Also doing interventions, we'll share with you, again, SERP, alternatives to suspension. We have some links for you that doing that now is critical before, as Rob said, it gets down further to indicated prevention or even folks just, you know, developing cannabis disorder. And then also in our city, we have the police use SERP as when they come upon a juvenile that they are given a choice. Would you like a summons or would you like to do SERP? And then the summons goes away. So really getting law enforcement involved too. Let's go on to the next slide and I'll talk even faster. Here is our substance use policy here at South Portland, and also similar to our athletic code that we changed. So just an overview, and again, we can give you all of these handouts and things, but instead of sending someone home for 7 to 10 days, which is what we used to do, now the student gets caught vaping in the bathroom, using, or they're impaired, the assistant principal, there's a wellness check with the school nurse. If we need to involve the school resource officer, he might be on board with that. We do out of school suspension if someone is drug dealing. Then we call the parents, come get your kid and let them know what's going on. And then they come back the very next day and they get a formal assessment from our school social worker. Or in the past, we have a licensed alcohol and drug counselors. And then they go to our in-school restorative classroom where we have a full-time staff member, and they have to go through kind of that behavior chain of what were you thinking at the time? Who did you harm? What are you going to do differently going forward? They kind of have to answer all of those questions, actually write them out. Their parents, the admin, a social worker, whomever is involved, maybe a teacher, figures out the best process, what is needed because of that assessment. So as a student, like, this is the first time I've ever vaped, I don't even know, someone just handed it to me, versus someone who's further along that might need some additional resources. And so we have the response plan, which might include, we have a vape intervention, we have SERP, we had to add community service, not like picking up trash in an orange jumpsuit, but working at a youth serving agency like Boys and Girls Club or our school community center for students. And so that they're working with someone who already works with young people. And they also might need to meet with one of our behavioral health liaisons from the police department. So again, this is kind of our process. And also our athletic code, we don't kick kids off of teams anymore. They still get to go to practice and meetings and be at the game. They don't get to play in game for 10 days. And this was a hard sell because some people are like, it's a privilege to be a Red Riot. And you're like, okay, he's 14. You know, and again, our students, athletes met with coaches and said, when you kick someone off a team, they don't come back, or there's a lot of secrecy and shame when someone is, and we actually have a voluntary part of our policy where someone could go to staff and say, I am struggling, or I have a friend that's struggling. Before you get caught, you could come forward. 70% of our students that had to see the licensed alcohol and drug counselor continued to see her, even though they only had to meet with her once. So really looking at this as a clinical issue. And then again, with athletes, we do captains trainings now, and we do much more support for peers who have an influence on others. Let's move on to the next piece. Okay, I want to just really quickly, do I have like 2 minutes left, Matt? Probably.
Yeah, just a couple minutes so that we have
Okay.
plenty of time for questions.
All right, I'm going to fly through this. Let's go over what doesn't work, because I think that's really important. Sometimes people kind of think, let's do this, and what doesn't work. Scare tactics don't work, and here's why. People will hear it, and they'll either go, yeah, right, denial, that's not true, especially if you go like, and I know there's the one pill can kill, big posters out, or don't be the drug dealer. You know, I have some of those kind of big signs. Those things really don't work, and sometimes it can be harmful. So denial, avoidance, it's too scary, I don't even want to believe it. Numbing, disbelief, skepticism. Wait a minute, I know someone who uses, and this has not happened to them. Making fun of some of the messages. Remember the old egg in the frying pan? This is your brain on drugs with a side of bacon. Also, don't compare cannabis to other substances. You'll hear people go, well, at least it's not heroin. So I've heard parents say that. Or if you're going to use something, you know, it's natural. Don't compare it. Compare it to not using anything, right? One-time assemblies don't work. Personal testimony from people in recovery does work for young people in treatment, but really is not good when we were talking, Rob was talking about universal, like doing an assembly with someone. And we really did used to bring someone in an orange jumpsuit who was in prison to talk to 8th graders. Not effective. And then again, don't do myths and facts. One of the bummers is, it turns out people remember the myths. So if you're walking by, I used to work at USM, and there was a thing that says the flu shot causes the flu. And then, you know, underneath, like, not true. But if you're walking by, that's the only part you remember. So people remember the myth, not the fact. Car crashes don't work. And I know that's old school stuff. It has a 36-hour impact on the brain. So you'd have to be watching it while you're putting on your prom tuxedo to have any impact that night. Drug fact sheets. How many people did a term paper in health class when you were in 9th grade, right? Like, not terribly effective. And then also, don't do role plays that have people be pretending they're drug dealers. You can do role plays on refusal skills using other examples, because that's important, but not drug dealing. Okay, next slide really quickly. So just one of the big things you can do that's helpful with any age group and adults and all that is using the pros and cons kind of quadrant, and have young people brainstorm the pros and cons of using. And you start with the good stuff. What's the good stuff about using? And they'll brainstorm. It's fun, relaxing, helps with anxiety, I fit in, all those things. What's the cons? Anxiety, you know, like addiction, all those not good things. Cons of not using: not many friends, not fitting in, left out. Pros of not using: healthier, save money, all that. And then processing those boxes and really saying, if I use, does it definitely mean I'll go to the cons? No, not always. And that's when we say, that's why we don't use scare tactics, but it could happen. And finally, before we finish up here, could you get the pros of using without using cannabis? Can you fit in? Can you make friends? Can you relax? Can it help you escape? You're like, what other things could you do instead? Okay, next and final slides, I believe, is here's all these great resources. And again, a lot of you know connection is the opposite of addiction. Some of the other good sayings are dare to delay. So what if you waited and didn't start? Like, this stuff will be around when you get older. It's not going away. Or not never, but not now. So those might be some good things for parents to say. So I've yammered on. Let's bring on the questions. Please reach out to Rob and me for our slides and our information.
Awesome. Thanks, Leanne. You're such a good impressionist when you do the impressions of what people say. You should consider going into that as a, some kind of a profession or hobby.
Thanks. I do have a theater minor.
That makes a lot of sense. Okay, so one question that came into the Q&A, and then I have a couple questions that I'm curious about. This question was about perception of harm and how, our first webinar covered the health impacts and potential, low perceived risk surrounding cannabis use among young people in the state. So how do we increase that perception of harm without using scare tactics? So Leanne, you went into this a little bit, but can you say more, and Rob as well? How do you increase that perception of harm without using the scare tactics? Because that is connected to people potentially using. So what do you think?
So I can jump in. So some of this goes back to some of those other strategies. So when it's not necessarily a direct correlation, right? So if I'm changing perceived risk, some of that might come out at how available it is in the community and how much messaging are our youth seeing when they're driving around town or riding the school bus. I mean, people get confused on some of the language, like what's a dispensary versus a retail establishment and those sorts of things. But when I would go into school, they're like, I passed 9 dispensaries on the way to school today. And, there's some truth to that. They weren't actually dispensaries, but they were constantly bombarded with messaging that seems positive around cannabis, because if it's dangerous, why are we promoting it so much? So we have to have those conversations. And again, like the notion of parents setting clear expectations, like what Leanne was saying, like, I'm not saying don't ever use, but how long can we delay? We know it impacts the adolescent brain. And I think the other thing I would say, sometimes we have to provide some information, but what you're providing, you need to make sure it's factual. And when it comes to cannabis, there's still a lot we don't know, and acknowledging that. But there's also this, like, we don't know some of these long-term effects. And, like, do you want to be the experiment? So if we delay, maybe more research will come out and we'll know more about it.
That's super
Yeah.
helpful, Rob. Yeah, Leanne, go ahead.
Yeah, absolutely. And not to make stuff up, and, just again, the REM sleep thing is always, and state dependent restriction are always very poignant in the brain, kind of going, oh yeah. And I've had students during a class go, yeah, I don't dream. And you're like, and then it takes 2 weeks to get your REM sleep back after stopping. So that's the other bummer, is like, it's not working. I'm going to keep using.
Yeah, and encourage folks to submit their questions in the Q&A. I'll ask one myself right now. So I spoke to someone recently about youth mental health. I know that Maine has some of the higher rates of anxiety among young people in the country, and 40% or more, I think more than 40% of young people in the state feel they don't matter in their communities, which is connected to potential for substance use. So how do we tackle that part? I mean, that's a big one. Do you have thoughts on how we take care of these other issues you've mentioned, perception of risk and harm, but also how do we make sure young people feel that they matter in the communities they're in? Leanne, do you want to start, since you're already on my screen?
Sure. Yeah. I will say this. One of the big things about working in coalitions, that you're working also with the adults who have an impact on young people. So if we are, again, that connection's opposite of addiction, how are young people getting connected to healthy choices? Which again, sounds like a boring poster, but can students be involved in things? Is there an after school bus? I mean, there's things you might not even go, what? We just found out it costs money to go to any athletic events. What if you can't afford the $5 to go to the basketball game? Think about adults in the community, like coaches, like teachers, parents, anybody that has an impact on young folks, and changing your policy from being punitive to being clinical and helping someone along the way to reroute their path. And again, the benefits we've seen, because people are like, hey, is your policy even working? Yes, We have students that are getting the support that they need. One student was like, I refuse to unturn my pockets of his stuff in front of the assistant principal because he thought he was going to get suspended for 2 weeks. The assistant principal reassured him, out comes the pockets. And the student is doing really well because he's been able to get help. And again, treat this as a clinical issue. So mattering is the connection piece, and that there's healthy adults out there in the community. And we've also changed our policy now at community service, youth serving agencies like the Boys and Girls Club. We had a student that was once brought a knife to the community center. He was in 8th grade, and the head guy was like, he needs to be banned for a year. And maybe we should let the Boys and Girls Club know too, and ban him from there also. Luckily, there was a really great coordinator said, why don't we meet with the kid and his dad and get him to sign a thing that says he won't bring knives. So again, or you'll hear like a teacher once advised a student in front of his parents because he was sharing that he had anxiety. And the teacher did say, have you ever tried using cannabis? It's really helped my daughter. You're like, oh, no. So really, again, educating adults in the community, parents, teachers, to go, hey, it's actually really not good for the young.
Yeah, Rob, anything to add to that?
I don't think I've been reading the other questions, honestly, looking ahead. So I think Leanne I don't have anything to add on that one.
Yeah. Well, so we did have a question that talked about something you just referenced, Rob, about don't be the experiment. So how do you respond to, on public health issues, sometimes we don't have all of the information, but there are instances where we ask people what we know is enough to feel that is safe for you to do X, Y, and Z. So how do you respond to that? And do you want to just say more about what you mean by don't be the experiment on cannabis?
Yeah, and part of that, like, I really try to sit and find my words, right? And we know words are really important, so that might not have been the best choice of words, but there's simply a lot we don't know. There's some stuff we do know, okay? And if I had a youth that might approach me with that type of question, it utilizing some of that motivational sort of approaches, it sounds like this is something that's really important to you. Let's talk a little bit more about that. Recognizing that there is still a lot we don't know. And sort of going along with that other, like, maybe there are some benefits, okay? But are they benefits with particular parts of the plant? And that's where some of the other presentations get into some of those differences, like when we're talking about, THC versus CBD and some of those things. My experience has been the general public doesn't have an understanding that there's a difference between those, and recognizing that cannabis products might be high CBD and low THC, but they can also be very high THC. And within those, we're talking about different products that are also going to have different results. And when we think about anxiety and some of those things, that's one I hear a lot. I work in a behavioral health agency. We hear a lot of people say, well, I'm using it for anxiety and it works. And we challenge that a little, right? Because we also know it can make anxiety worse. And oftentimes what we hear is people saying, well, I did try going off from it and my anxiety got so bad. Well, guess what? Also, part of withdrawing from cannabis, part of the withdrawal symptoms is anxiety. So is it that my anxiety is getting worse, or that I'm in withdrawal at that time? So
Yeah, and I want to chime in
yeah.
too. So Leanne, you said dare to delay. And when you and I talked offline about this as we were preparing, the issue is that for a lot of the health impacts that we do know about, they're for young people. So there's a big difference between talking about adult use of cannabis and potential benefits of use versus adolescent use of cannabis and those potential benefits of use. So I think am I right in thinking, Leanne, that's where the dare to delay comes in as a tactic?
Yeah, and I think, a couple of things I didn't say in my other slide. One of the great protective factors is future aspirations. So really getting people to think, like, what do you want to do after high school? And it doesn't just mean I'd like a career in the medical field because it's well paid. It's not only like your career, but do you want to travel? Do you want to learn a new instrument, right? Like, so future aspirations is a protective factor. So if you don't already have this, have a subcommittee in your world that focuses on future aspirations for young people. And that again gets into the mattering piece. And hey, if I screw up my brain now, you know, like I'm not good at short-term memory or my learning's not great now, how might that impact down the road learning and possibilities and experiences if I am having trouble at a young age doing that? What does that look like down the road? And then one other key thing I forgot to mention too is that a risk factor for young people and really any age is that cannabis delays or really interferes with your gag reflex and inhibits the gag reflex. So if someone is drinking alcohol and using cannabis at the same time, that's really a risky combo, because if you've had too much alcohol, your body will vomit. But if you're using cannabis at the same time, you're not able to vomit. So just kind of, again, knowing, like Rob was talking about, like, are you vaping it? Are you, you know, eating it, edibles? All of those other pieces are really important to go over with young people.
Yeah, thanks, Leanne. And so one quick question on mine, and then I'll ask, I think, the last audience question. When you said, here's what not to do, and you said several times, this is not effective, this is not effective. Can you say more? This is not your opinion, right? It's not effective based on evidence and research. So can you say more about that part of it? When you talked about the, you know, one-time assemblies not working, what are you basing that off of?
So yeah, there's just, I have some really great handouts and a booklet about why scare tactics don't work or why those things. There's a great tool that I can send to people, or to you, Matt, to others, about what works and what doesn't work in prevention. And that really outlines what does and doesn't work. And sometimes, you know, I've had people go, can I do an assembly? I'm a professor of ... and I just have a 57 slide presentation I'd like to share on the dangers of opioids. And I kind of said, no, you know, like in a nice way, like that is not effective. And it's actually can be harmful to people, some folks seeing that. And yeah, but for the ones that do need it, you know, like, no. So we do have research on what works and what doesn't. And it is tempting. I know we used to do a program called Every 15 Minutes, which was how many people died in car crashes. Every 15 minutes, someone would die in our country. So it was a cool thing you did in the school, and you had kids get out of the room every 15 minutes, come back dressed in black, who were dead, and they didn't speak the rest of the day. Well, then the research came out that it was only every 30 minutes that someone died. And I had to kind of break it to this group, like, you guys, it's actually every 30 minutes, getting better. Yeah, but we have the video. We still want to use the video. You're like, no, like, so again, you're going to have people, students are sharp. They're going to go, hey, I just saw it's actually every 30 minutes. So this is crap. So I think we have to be really astute in our ever-changing information. And we only know what we know now. Like, we're going to look back later from now and go, oh, maybe that didn't work either. But we have better information about what didn't work.
Thanks, Leanne. So really quick, somebody asked in the Q&A about clinical trials and research on cannabis. I would just direct you to the first webinar that I think covered some of that, just given the time we've got. And I'll share the webinar in the chat. I also just launched the poll that folks should fill out as we're wrapping up here. It's like 4 questions. It takes a minute. And then there was a question in the Q&A. I know we're talking about youth prevention strategies, but this person asked, what methods are out there for minors who are currently using cannabis and have no intention of ending use? And they provided context that they don't want to ruin the trust that they have with students who are using, but are not sure how to navigate that situation with them to, you know, encourage ending use, but that person has no intention of ending use. So any thoughts on that, Leanne and Rob? And then I think we'll wrap up.
Yeah, that it can be a tricky one. So depending on what your relationship is and what your, you know, regs are around confidentiality become an issue, because I can't talk to anybody else. Adolescents have the right to confidentiality from their parents, depending on your licensure. So be mindful of that. So it's really about engaging them in a conversation. Maybe they have some concerns. So again, how am I reducing some of those risks or those negative consequences that I may be experiencing related to my use? So one example, I think of like during school, if I'm constantly getting in trouble and having violations at school because I can't make it through the day without going outside to use or something, having conversations around like, how do I manage my use? How do I maybe reduce so I'm not having those negative consequences? And is the individual even at the point where they're recognizing? So some of this is going to be up to them in their own readiness. But just being there, being a support, and being a person they can continue to go to.
Thanks, Rob. Leanne, anything to add?
Yeah, definitely doing some harm reduction approaches. Again, if someone's driving, they're saying now with high potency, you have to wait 12 hours before you're not impaired. And again, depending on how much someone's used, it's so unpredictable. And Rob and I were talking about, there's no legal limit right now for cannabis. Is a 0.08 for alcohol if you're over 21. There's not for under, of any kind. So we need to improve our detection and things like that so that we can help. Again, just having taught the deep class, there's a lot of students would share they were suspended from school. They were kicked off an athletic team. So you think about what if we had helped them sooner? They would not be here with an OUI that they lost their license for 18 months and now it's costing an average of 10 grand for an OUI. What if we had figured this out sooner? Amen, right? Like do it now.
And Leanne, I don't know if you remember the data, but keeping in mind, Leanne referenced high potency THC. Most of the cannabis that is sold in the state of Maine is classified as high potency.
Yeah, and with that, we should wrap up, but I would encourage folks tune in the same time, same day next week, Wednesday, for another series or another webinar in our series, excuse me. And that next one is going to be about medical use versus adult use in Maine. So encourage people to check that out. Thank you, Leanne. Thank you, Rob. This has been great. And I hope everybody has a good rest of the day. Bye.
Thank you.
Thank you.